I've been easy on you, Sharon. I'm just saying. I'm not going to be easy on you now, but there are these 3 indications for maintenance treatment after responding to second line or beyond platinum, and I'm not going to go through sort of the Solo 2 study 19, but they're not too dissimilar from Nova and Ariel 3. And certainly the first PARP inhibitor that became approved in treatment was 4th line, and it was only germline. And so, as Tom said, we've got a regimen line of therapy earlier in Recaprib, 2 priors, not 3. And as Tom Kreback said, we even have now beyond BRCA, we have an HRD molecular signature. So we have 3 treatment indications. I get it, the labels are different a little. We have 3 identical labels in platinum sensitive maintenance treatment. So the tough question for you is, in the setting of overlapping labels, which PARP?
So that's a great question. I mean, I think if you look at the hazard ratios on these trials, that these PARPs are pretty similar when it comes to efficacy. But for me personally, it really boils down to safety profile and tolerability. And I guess personal experience, which PARPs I've used the most on trial or off trial. Certainly can say I do have my favorites, but I think really the safety profile is what it boils down to.
So Tom Kreback, how about familiarity? Does familiarity play into that, or is it more safety? What do you think?
I'd like to think you get familiar and comfortable with the PARP you feel is the safest. And again, all 3 are out there. So my familiarity is going to be with the safest and the best, in my opinion. So I don't think we've ever had 3 drugs very similar come on in competition. So it's been hard for us to figure out, how to use it. But I think it's nice having choices. To me, I agree completely with Sharon in that, it's side effects. If somebody has really bad nausea, vomiting on olaparib, you can consider changing over to Recaprib or niraparib. If some patients are not as driven and may not want to take their medications as often, you have once a day dosing with niraparib. To me, I work in a large health system, and I think at some point it's going to be cost driven. Tom Kreback, you're going to get 2 PARPs. Which ones? Because we're going to go back and so I hope it never comes to one, because I really completely agree with Sharon. They're all not equal, and so the science is the science of medicine is understanding these studies. The art of medicine is taking each of these studies and applying it to the right patient, so we get the patient to be on the drug for the longest period of time. That to me, as I think, is the key.